welcome to the latest episode of The Rest is Plastics with me, Anton Fries.
And me, James.
Today is a very special episode. We're interviewing Miss Helen Douglas, consultant burn surgeon from Perth in Western Australia. And this is a paper, an invited paper for a special edition. So really great to have you on the podcast, Miss Douglas.
Thanks very much for having me, Anton and James. Please call me Helen.
Thank you. So the title of the paper is The West Australian Surgical Approach to Massive Burn Injury. And obviously, Chris invited you to write the paper for the special edition, but can you perhaps summarise the sort of genesis and why this topic was so important?
Yeah, I'd love to. I give a bit of a foreword in the paper where I talk about when he asked me to do this, so I was a bit perturbed because there's lots of people that know more about burns than me. But I think one thing that I do hold true is that burns is a team specialty. And I joined the team in Western Australia 10 years ago as a fellow and stayed on after that, becoming a consultant in 2017. And I think that burns have changed a lot. And I think that the topic's important because in the paper I quote Fiona Wood, who a lot of people remember from being very famous from the Bali bombings and inventing the RECELL autologous spray on skin. And when it comes to big burns, we always say that the quality of the outcome has to be worth the pain of survival. And that's so important with massive burn injuries because there's no point in getting someone through it if they, at the end of it, are not really able to function or go out. I think there's been a lot of progress in burns. It's a fascinating subject for me and the technology has come on a lot. And I think I've got a responsibility to share those lessons learned and take them forward. You know, I think it's unethical almost not to.
So Helen, can you tell us a little bit about your team? How big is it? You know, how do you work the rota?
Yeah, so we've got 8 consultants on our rota. 2 of us just do burns. The rest of them do a combination of different skills, including breast, head and neck, lower limb recon, trauma, and half of us, including me, do pediatric burns as well. And I think that's a bit of a shift as well because we've now got people who are not just burn surgeons, they do lots of other things, and that brings a whole skill dynamic to our team. You think about the young teenager who's transitioning to adulthood and breast development, you know, that's when we get Anna Goodwin-Walters involved. We think about, you know, the polytraumas where they're having horrendous amounts of flaps. You know, Sandeep, who's one of my colleagues, has done, along with JP Hong, a lot of skip flaps, which is brilliant for us. And when I'm doing a big neck release on someone who's got an absolute zero neck extension, I make sure he's with me so that I've got a very skilled head and neck surgeon. So we've got huge amounts of skills in the one team that we can bring together. And I think that makes a massive difference for us functioning.
And give us an idea how busy your unit is. How many people do you see? How what's the size of your ward? Because there are 10 of you, you said. Oh, sorry, 8 or 9 of you, sorry.
There's 8 of us on the rota. Fiona Wood is also the director of the service, but she is purely research now. And we have a 10-bed unit with surge capacity to go more than that. At the moment, we've got a load of outliers because it's been a busy week. We've also, that's the adult hospital. The paediatric hospital has a shared ward with orthopedics, but that's 20 beds. And we've got dedicated ICU beds that can be warmed in both hospitals, 2 beds each, which is, you know, very important for the massive burn injuries. We cover a huge area. You know, Western Australia is 2.5 million square kilometres. It's enormous. But pockets of residents are quite small. So the transfer times are usually via aeromedical teams over vast distances and can be measured in days rather than hours. So it lends itself to a very unique population, and anyone who's burned in Western Australia in that massive area, if they need an operation, they're coming to our unit. So it allows us a lot of things in terms of the research because we are able to use our electronic database to look back and analyse all of our data, which is a massive amount.
So to go through the sort of methodology of the paper, as it were, because actually it is a sort of it's a retrospective study, isn't it, over 2 time periods? Can you elaborate a bit on that for us, please?
Yeah. I was saying to James, you know, this is raw data. It's not sophistically analysed. But what we did is we looked at our massive burns, defined as over 50% TBSA, and looked at that over 10 years. And in the first 5 years, which is how long I've been here, but in the first 5 years, we were using Integra as our dermal substitute. In the last 5 years, we've used exclusively BTM, so biodegradable temporizing matrix. And we had all observed probably a difference in outcomes, but we didn't know it. So we looked back at our data and we looked essentially at all of the usual epidemiological things, but also concentrating on short-term outcomes. So mortality, looking at length of stay, and looking at the healing times. So we did all of that and looked at some ranges and means, and came up with some data, which, as I say, pretty raw, but supported what we all kind of felt. And that's going to be more interrogated later this year. Mostly because last year we had 30 massive burns. We have a lot more major burns, over 20%, but we had 30 massive burns in 10 years, which is about 3 or 4 a year. But last year we had 15 in 1 year. And that trend of increasing, we're going to have to look at this data a bit more closely. It gives it an opportunity for us to see if these are borne out in an incredibly crammed in time space. So we're hoping to look at that later on this year and get it properly analysed.
Yeah, that's a fascinating finding, and perhaps we'll go into that in a bit more detail. But I was just looking at your results, so perhaps you could just, I mean, you mentioned not doing the stats, but the numbers are quite, I mean, particularly the times of healing are quite impressive. Can you go through those for us, please?
Yeah, thanks. I'd love to. So we looked at mortality overall, and the mortality of massive burns. I mean, they've always been hard to keep alive. They probably always will be. But what I think we found is that even though our overall mortality was about 50% for massive burn injuries, the vast majority of those were palliated within 24 hours for futility. And palliation is something I don't go into in depth in the paper because I think it could form a paper itself. There's emotive subjects, they are very difficult decisions to make. But in our hands, they form available donor sites, depth of injury, and availability of functional areas such as hands and face. So the ones that were palliated were done within 24 hours. And that left us with an overall survival rate of about 18%, which is pretty good for a massive burn. When we split that overall group into two, and like I say, the difference in those 2 years was essentially the dermal template used, our mortality in the first 5 years when we were using Integra was 22%, but 14% in the second time period. Our length of stay reduced, not huge amounts, but from 82 days to 74 days, which, does have an implication for the patients and cost implications. But as you say, the major thing was the reduction in healing time, which we measured indirectly as time in dressing, which is quite easy to see from the database. So once the patient was completely out of dressings and discharged from the dressing clinic, we took that as time to healing. And that massively reduced from 7 months pretty much to 4 months. And I think that was the big win for us, because that obviously has knock-on effects on scarring, functionality, return to work, and psychological impacts.
That is really impressive, isn't it? And if that's kind of reproducible or applicable in other areas, then that's going to change the face of burn care, I'd have thought.
Can I jump in there? Question. I mean, probably a stupid question, Helen, but the reduction in the mortality rate. Do you think is that directly a result of the time it takes to heal the wound, or is there something else going on there?
It's a good question. It's one I'd like to look into a little bit more elegantly. But there's no doubt that we used to see those. We used to call them the 3 time points of death. 3 days, 3 weeks, and 3 months. So the 3 days were the people who unfortunately just did not have the capacity or the reserve. Usually measured nowadays rather than by the Bow score as physiological scores, Apache, and so on and so forth. Those people that just could not survive that injury or were palliated early. The 3-week kind of deaths were the ones that almost ran out of steam. So, really got early overwhelming sepsis. But I also think, and Sian Falder showed this when she was the fellow, now obviously she's head of department in Wiston, but when she was the fellow here 20 odd years ago, she showed that if you put Integra onto a major or massive burn in an adult, 33% got infected and fell off. And if that happened, 50% of those patients died. So that was a massively, tragic statistic. But it did give a bit of credence to, well, maybe that's one of the reasons those people, because once your Integra falls off, I don't know if you ever used Integra, but you couldn't really put anything back on until you cleared the infection. And some people, you couldn't do that and they would just die. So I do think that the template change and the time to healing are intrinsically linked, because BTM is so resistant to infection. That's becoming really accepted now. We've just had a publication accepted for a pediatric series where we showed we had 0 loss of template in any pediatric major burn. And that really means that they're not getting catabolic, they're not getting infected, and that then, yes, they can progress to healing. And the knock-on effects of that, I think, are huge for the mortality. I haven't proved that yet, but I hope to.
Because another thing that you mentioned is that you guys no longer use allografts.
Yeah. And this is a trend we're seeing all across Australia now. I used to use a lot of allograft when I worked at Pinderfields. There's no doubt it works and saves lives. But I think it is temporary. And I think that the temporary nature of cadaveric skin, like I say in the paper, combined with the fact that it massively increases your HLA sensitization. Peter Dvolsky and Quentin Frew presented that in Vienna in 2013, and there was just a collective sort of intake around the room, because that has knock-on effects for solid organ and I think they were looking into it for the composite allograft transplants, but and then combining that with, actually, it's now becoming a lot harder to store it, the overall costs, needing a tissue license, the shelf life. Add in the recent problems with, supply lines and geopolitical events. BTM's got a really good storage life. And I think all of those things factor in now that we just cannot see a reason to use it anymore.
What's the etiology most commonly of these massive burns, and can you speculate why the incidence has gone up recently?
In Western Australia, there's a lot of industry, mining, oil and gas, things like that, and some of our major burns are definitely because of that. I would say the majority of the massive burn injuries are either burn offs, because we have a lot of farming and fire bushfire prevention strategies here that sometimes work and sometimes don't. So bushfires, bushfire prevention, car crashes and farm incidents are our major ones. I think they're all almost all of them were flame burns, for the massive burn injuries. Why was there 15 last year? I don't know. We certainly had a few more road accidents that survived. I think more of them are surviving. So if you'll have a look at that table in the paper, what hadn't changed over the 10 years in those two groups were the numbers presenting and the numbers palliated for futility. But I wonder if now we're seeing that improved survival with less infection, if we are now maybe pushing the boundaries on it and there are just more who is going to survive. However, it doesn't tell me why there were more presenting. So I don't know. I'll find out and tell you.
It's interesting, isn't it? Because I think a lot, historically, burn injuries have kind of reduced as sort of prevention strategies have been effective, and I think some units would say that like self-inflicted burns are quite common in terms of the proportion of the massive burns. Sounds like that's less relevant in Western Australia?
Yeah, I mean, we have our share of those, but they do not form a majority, that's for sure. Unfortunately, those are often the ones that are very, very severe, just due to the nature of the immolation and the accelerant. But we do have a few of those, but they're certainly not the majority. The majority are road or fire accidents.
And you've alluded obviously to the sort of BTM being a definitive kind of change, but I suppose that, as you've said in your paper, there must be other things that have improved in the last 10 years that are contributing to those really great results. Do you have any other thoughts as to what? I mean, it's really hard to tease out, isn't it? Because you're obviously this amazing team doing all these different things. It must be very hard to tease out what else makes a difference. But are there other things you have a sense that have generated those improvements?
I mean, I think that's a massive one. I think that showing that you can control sepsis, which, if you don't control the sepsis, they will all die before you can get them covered. It was a race to get them covered. And with a massive burn, you're just not going to win that race if you get the overwhelming sepsis. But other things I think have helped, critical care strategies have improved. We talk about time to theatre, which is sometimes a bit of a controversial topic. There's lots of people that will take people to theatre and immediately remove all the burn. We actually had the benefit of looking back at a lot of our data and seeing how they do, and ours do better if we take the burn off between day 3 and day 5. Like I said, sometimes we don't have control over that because it can take 2 days for them to get here. But I think that the fluid shifts and the edema control so that you can get that BTM to stick is, in my mind, is probably a really important thing. So that you're not having wound die back because of edema and then reduction in that causing wound bed problems. The other thing I do, and I mention this, I bang on about it a lot, I don't want to sound like evangelical, but having that protocolized surgical team agreement between you all, it really is key to being able to get these all done in the same time, the same fashion. You're waiting for a different time. You're not taking them to theatre at a time that doesn't suit, with less team members, taking longer on the table. I do think that those things have definitely been crafted over the last 10 years. We have 3 new consultants since I became a consultant, and having more people gives more flexibility and allows you to not burn out. So I think it's a myriad of things, but mostly BTM and the protocolized direction.
So Helen, you work in this all singing, all dancing unit with really aggressive management. I mean, I can see in your article here, you talk about the different phases of management, immediate and all the different phases post debridement. You talk about eschorotomies, you talk about Nexobrid. You get people vertical as early as day 1 post-op on the tilting table. Can you just talk about that aggressive nature of management and how you as a team can implement that so consistently across the board?
Yeah, it's a great question, and I think someone I'm stealing this. Someone said it to me recently. All problems are leadership problems, and it really rang true. We've had Fiona has crafted this. I took over as head of department 2 years ago, but there's an expression in Australia called doing a Bradbury, because there was a chap called Stephen Bradbury who basically waited until, Anton's nodding, I think he knows this, who waited in the Winter Olympics until everyone fell over skating and then came in and won. And I've definitely done a Bradbury here. Like, this team was well established and crafted before this. But Fiona and Suzanne and Mark and Anna, actually, Anna was the fellow during the Bali bombings a long time ago. They have worked together to get a team, and after a massive disaster like Bali, I think the funding was definitely there because people saw a need, like with any disaster. So Fiona was able to make a list and design her burns unit based on the fact that they've gotten such great outcomes from the Bali bombings. And that included a physiotherapy professor who I've referenced in the paper called Professor Dale Edgar. And he is probably the driver for the early mobility. I remember when I visited here as the fellow, and they were like, yep, as soon as they're grafted, they're in the gym. I was like, sorry, what? I said, yeah, day 1, maybe day 2, if we're being kind, they're in the gym. And I thought it was nonsense, but it's absolutely true. There's him and 3 other physios, and they are trying to get patients. And that the paper that I reference of his in the article does say that that's harder when they're on huge doses of noradrenaline, obviously. But they've got intubated patients on a tilt table, achieving functional vertical milestones, preventing that orthostatic, autonomic disruption, dysregulation from day 1. We don't always get it, but I think it's that twice weekly MDT. This is what we're doing. This is what we agree works. And if we're all united in that, then there's very little disparity. I think apathy can be contagious, but so can enthusiasm. And I think Fiona is absolutely key in that. And just making sure that we're all still on board and engaged with it really regularly.
And it was heartwarming to read the section that you emphasized how important it is to build those relationships within the team.
I think Chris thought I was a lunatic, but I think it's so important, and not like I'm only joking. Chris Lewis was our fellow; he knows exactly what it's like and stuff. But you know how when you design your team, now we've got a head and neck surgeon, we've got a lower limb surgeon, we've got I just do burns, but we've got a lot of people involved. But if your personalities don't mesh, if the culture isn't right, it's a disaster. So I think, and you don't all have to be best mates. I mean, that's ridiculous. But we do invest that time in each other, and it is just, like when you were trying to order a scan as a house officer, if you actually went down, your success rate and talked to someone face to face, your success rate was just so much better at, that interhuman connection. And it's the same with your colleagues. If you actually spend some time with them, even if you're very different, you're so much more likely to let that annoying thing that they did just slide, let one past the keeper there. And you're so much more likely to just pitch in because you've invested that time in them. And I so believe this. And Rachel Baines, who's one of our most recent recruits, who's done a bit of time in the States doing some leadership stuff. She is just instrumental in this now. Her husband's a really good cook, and we just have dinner usually at their house twice a year. And it doesn't sound much, but it makes a big difference. I really, really, truly believe that.
But surely there must be times when you guys disagree about a management plan.
Oh yeah, and I do put that, we all have differences in our practice, and things that I can think of are like, diabetic feet, long lies. There's areas of each, even within burns, that we do treat differently. But I think when it comes to a massive burn, in that specific situation, we are all agreed that this is probably the best way. Because we've shown it, we've done it before, we've shown the data, we've looked at it again. We all do slightly different things. I'm a real fan of Matroderm on hands in most situations. Fortunately, JP Hong came over recently and agreed with me on that, so I felt very validated. But not everyone does. But if we keep to a general plan for a massive injury when the stakes are really high, and I do, I'll put my that'll be the hill I die on. We all do agree with that, and we all do get together, despite having differences in our practice, of course.
Yeah, those teams and systems are fundamental, aren't they? It's like, obviously you've demonstrated it in burns. I think other groups have demonstrated it in lower extremity free flaps and orthoplastic practice and timing those. And you have to take the surgeon out of it sometimes, don't you? And it's like with this system function, if someone else was there, with that training, adopting that protocol, and if the answer is yes, then you're really winning, aren't you?
Completely agree. It has to be a system, and it has to function without you. Otherwise, it's too fragile.
Yeah, the vertical ITU therapy stuff is amazing. Sounds amazing as well. How long have they been doing that for? Was that since the Bali bombings?
Yeah, that predates me. There's a really good photograph of sort of one of those ones that obviously isn't digital, has been taken with some kind of developed film of Dale and three of the physios getting a Bali bombing victim walking in 2002, like looking like a mummy, but they're up, and he showed all of the outcomes were improved, from the length of stay, days intubated, something to do with that orthostatic, autonomic thing.
I guess wrapping up, you've been through your paper and your experience, and we've touched on some differences, around the world, whether it's sort of etiology, and you have this very interesting cohort with the delayed presentations, and you capture this huge area and things. How do you think your results and your practice, can it be completely applied to, say, a really intense metropolitan area or different cultures around the world? What do you think? What do you think other groups can take away, and what perhaps are the differences they might face?
Yeah, I think that's very valid, actually. Because we get fellows from all over the world. Our fellow who's just gone home was from Switzerland. The one before that was from Canada. We've had a lot of UK fellows, and what works for us won't necessarily fit into their model of care. 100%, agree with that. But I think that there's certain things that will. And there's certain things that can fit into even resource poor environments, such as taking your skin grafts really thin, rotating them and taking the patient back every 10 days to get that healing. You don't need to have a massive budget to do that. So I think that there's elements of the protocol, and that's one of the reasons why I wanted to share it. There's elements of the protocol that might fit into other people's model of care. We really struggled to fit Nexibrid into ours until we started just putting it on at the start of the operation so that they were asleep. It's been around for a really long time. We really struggled. It's got to fit in with your model of care and your the way that you work. But hopefully there's some bits in there that they can do that.
Yeah, the Nexibrid thing did stand out. So you start the case, you put that on the face, and then do the rest of the case. That's how it works?
Yeah. Well, in a massive burn, we probably prone them first, take all the skin off the back and debride. But then when we flip them, we've probably still got 3 hours to go. So you just put it on. And it's just been a game changer, you know. Like, I'm not as accurate as the Nexabrid with my Derma Radar knife, and anyone who says they are, I think, is kidding themselves. You know, and in some functionally really lovely area, you know, some really good results we've got are due to dermal preservation and getting that dead burn off quickly. And then all of us who remember those terrible facial burn scars, you know, we'd do anything to get that better. And not give those people that burden. And I really think Nexabrid can do that.
They could lie face down in a puddle of Nexabrid.
They probably could. I've not done that. I've always done it supine, just because it can run places. So there's people putting goggles on them. There's, you know, we stitch gel in at bolsters. I've not been brave enough to do that yet. I've always done it when they were supine.
That's my contribution to burn care.
Thanks, Anson.
I find it. Yeah. So what I found fascinating, Helen, is that you started off almost apologizing for not having some very sophisticated stats, but actually, I think your article adds so much value to the literature. You know, sometimes we do require narrative reviews where people share their kind of real world experience without necessarily lots of sophisticated stats to back all the different bits of nuance up, especially the bits about the, you know, the softer bits, the team building, the human side of things, ever so important. And I think that's really neglected in the literature. But just for the listeners who may not have had the chance to read your article yet, can you just give us a few the key takeaways, maybe 5 or 6 points that they need to just, you know, learn and maybe think about applying in their practice in future?
Yeah, sure. I think I'd probably say massive burns are really hard to keep alive, and they always will be. But I think that the technology and I think that the techniques that we talk about, mainly the different dermal matrix, BTM, and having a structured surgical approach to getting that burn off and getting them covered in a reliable fashion, means you can get really good outcomes functionally and aesthetically. And more importantly, get these people out of hospital and healed earlier. So I think those are the main takeaways from that. And as a nice little aside, you know, if you can have an environment where you can work and all work together to get those outcomes, it's not just better for the patient, it's more enjoyable for you as well.
Helen, that's a great message to end on. Thanks so much for joining us. We really appreciate your time, and we'll hopefully catch up at some plastic surgery meetings soon.
I'd love that. Thank you so much for having me. Cheers, guys.
So there was Helen Douglas, Head of Department at the Fiona Stanley Hospital Burns Department. So those that we got through there, Anton, what were your key takeaways?
It was sort of cutting edge burn care in 20 minutes. Could pick out any number of things. I think perhaps the thing that maybe resonates even beyond burn care is her comments about team working, systemization of treating complex patients, because I think that's applicable to, you know, almost any aspect of surgery, particularly when you're dealing with complex problems, whether that's major burns or open extremity trauma or head and neck cancers or any kind of multidisciplinary working. So yeah, I thought that was great, and all problems are leadership problems was a good takeaway.
Yeah, and I was astonished how aggressive they can manage the patients straight away. You know, that was amazing to me. The tilting of the patients at day one.
The day 2 hand therapy with skin grafts on. I mean, that would be. I mean, I'm sure we used to put K-wires in people's hands that we skin grafted once upon a time. So it's amazing, even in our very short careers, James, that things have changed so much.
And for listeners, if you do manage to get to the article, have a look at the figures, because there's some absolutely incredible outcomes there. There was one, I think figure 6, where they showed how pliable the skin was over a burnt hand. The other thing that was fascinating was the BTM, the outcomes of BTM, so much better than the historic cohorts.
Yeah, absolutely, and you know, it's great. It's great to see some of this technology making a real difference, because you know, there's a huge amount of these products out there, and it can be quite sort of overwhelming, because obviously on the one hand you want to do the best for people, but on the other hand you don't want to vanish down a sort of resource intensive rabbit hole without actually benefiting anybody apart from perhaps the shareholders of the company. So you know, it's really great to see here something that's sort of definitively beneficial.
And probably one of the hardest subspecialties in plastic surgery, the massive burns. So good on them.
On that note, we'll wrap it up, James. Until the next time.
The rest is plastics.